Welcome to Chapter 33, entitled Pharmaceutical Care in Viral Diseases, HIV and Hepatitis C. Pharmacists are well positioned within the care continuum to help patients achieve their treatment outcomes as they are easily accessible, are in contact with the patients when they visit the pharmacy at treatment initiation and overtime for refill visits, and they have education and training in the management of drug-drug interactions and adverse effects. In this chapter, we highlighted evidence-based pharmaceutical care interventions in adherence, which is an important drug-related problem in HIV and hepatitis C infections. We will now look at an introduction. There are about 2.4 million people living with HIV in Europe, 36.7 million people worldwide. Globally, 150 million people have chronic hepatitis C viral infection, which is about 2 to 3% of the world's population. In industrial countries, it is the most frequent cause of chronic hepatitis and hepatocellular carcinoma and the main indication for liver transplant. 10 to 30% of people living with HIV, abbreviated as PLW-HIV, also have hepatitis C co-infection, which accelerates the impairment of the liver. However, since directly acting antivirals, abbreviated as DAAs, against hepatitis C have good clinical outcomes for patients mono-infected with hepatitis C virus or co-infected with hepatitis C virus and HIV. The World Health Organization guidelines state that HIV-positive patients co-infected with hepatitis C virus no longer need to be considered as a hard-to-treat population. However, the main actual challenges are risks of drug-drug interactions for HIV-positive individuals co-infected with hepatitis C virus, and for individuals with HIV or hepatitis C virus suffering from other comorbidities, e.g., cardiovascular, depression, tuberculosis, medication non-adherence and access barriers to these expensive drugs. Knowledge in pharmacology and pharmaceutical care are key factors to ensure the success of HIV and hepatitis C treatment, which means ensuring the clinical and economic efficiency of the treatment as well as the patient safety. We will now look at disease definitions. Let's begin with human immunodeficiency virus. Human immunodeficiency virus, abbreviated as HIV, is a retrovirus that causes HIV infection, and over a long period for untreated individuals, causes acquired immunodeficiency syndrome, AIDS. HIV attacks the host's immune system, destroying a specific subset of T cells, CD4 lymphocyte cells, reducing their numbers, which leaves the host prone to several opportunistic infections, e.g., pneumonia or infection-related cancers, e.g., Kaposi's sarcoma. It also infects other cells such as plasma cells, macrophages, and causes tissue inflammation throughout the body, which is strongly predictive of the risk of morbidity mortality. The three stages of HIV infection are acute HIV infection, clinical latency and AIDS. The acute HIV infection stage occurs within 2 to 4 weeks after HIV exposure in about 1/2 of all patients. The infected individual experiences flu-like symptoms, which is the body's natural response to HIV infection. Symptoms include fever, adenopathy, pharyngitis, headaches, muscle aches, and sore throat. Dermatologic symptoms such as ulcers are also common. The virus is using CD4 cells to replicate, which destroys them. During this period, the host is very infectious and can transmit HIV to others through sexual contact or needle sharing. Toward the end of this phase, The host's immune response will bring the viral levels to a relatively stable level and the CD4 count begins to increase to normal levels, but still below pre-HIV infection levels. Then the infection progresses into the clinical latency stage. During this stage, the virus is replicating at a very low level, and is in symbiosis with the host without producing any symptoms. This is why it may also be called asymptomatic HIV infection. This phase may last 10 years or longer in untreated individuals. Then, when untreated, the viral levels will start to rise and CD4 count will progressively decline over the years. When the level of CD4 cells falls below 200 copies per milliliter, or when the host suffers from one or more opportunistic infections, the HIV infection has progressed into AIDS. Without treatment, people with AIDS typically survive about 3 years. The progress of the disease differs among hosts due to several factors including host and virus genetics, how healthy individuals were before acquiring HIV infection and whether or not they were diagnosed and linked into care immediately after their exposure, which would improve their prognosis. Next we will look at hepatitis C. Hepatitis C is an infection caused by hepatitis C virus, affecting the human liver. It is a blood-borne infection and can be transmitted through the transfusion of unscreened blood or blood products, or sharing needles among infected individuals. The infection can be both acute and chronic. Acute hepatitis C infections occur in 15 to 45% of the cases. The infection is often asymptomatic, and the virus is cleared out without any treatment in 6 months. Chronic hepatitis C infections occur in 55 to 85% of the cases. After an incubation period between 2 weeks and 6 months, infected individuals exhibit symptoms such as fever, fatigue, abdominal pain, nausea, vomiting, and jaundice. Hepatitis C virus infection is the leading cause of chronic liver disease, cirrhosis, and hepatocellular carcinoma, as well as the most common indication for liver transplantation in many countries. Next we will discuss management of the disease. Let's begin with lifestyle. A new HIV diagnosis is devastating for many patients. HIV still has no cure. Thus, the dissemination of prevention and health promotion information is a public health priority. The impact of treatment on HIV transmission can be of greater effect when combined with behavioral change such as safer sexual practices, and harm reduction for people with intravenous drug use history. In addition, as a high level of antiretroviral (ARV) therapy, abbreviated as ART, adherence, that is 90 to 95%, is required to achieve viral suppression. Behavioral change such as adapting to regular daily medication intake is needed to maintain it in the long term. As PLW-HIV are getting older due to the success of antiretroviral therapy, pharmacists along with other healthcare providers must pay attention to lifestyle modifications to reduce risk of cardiovascular disease, e.g., increased physical exercise and smoking cessation. Individuals with an untreated hepatitis C virus infection are encouraged to make certain lifestyle changes. Most importantly, to refrain from drinking alcohol as much as possible, as it speeds up the progression to liver disease. It is also advisable to avoid blood contact with others through sharing razors, toothbrushes, or needles to prevent transmission to others. Next we will discuss medications. To the moment of writing this book chapter, no cure exists for HIV, but long-term viral suppression can be achieved through continuous treatment with ARVs. Treatment involves 6 classes of ARVs and each drug is classified according to the part of the replication cycle of HIV that the drug inhibits. HIV infection starts when HIV enters the human body and infects human CD4 lymphocytes. The first drug class is called entry fusion inhibitors, and it binds to CD4+ receptors and the chemokine CCR5 or CXCR4 co-receptors expressed in CD4 host cells, or viral GP41 or GP120 to prevent viral entry into the human cell. As HIV is an RNA virus, therefore it needs to reverse transcribe its RNA into DNA using the viral reverse transcriptase enzyme to be integrated within the nucleus of a human cell. Two drug classes inhibit the viral reverse transcriptase enzymes: non-nucleoside reverse transcriptase inhibitors, abbreviated as NNRTIs, and nucleoside reverse transcriptase inhibitors, abbreviated as NRTIs. The fourth class is integrase inhibitors, abbreviated as INI, and they prevent the integration of viral DNA strands into the host's DNA. The fifth class is protease inhibitors, abbreviated as PI, which prevent the cleaving of viral proteins needed to form mature viruses. Improvement of the pharmacokinetic properties of PIs can be done through the addition of a small dose of ritonavir, abbreviated as RTV, or cobicistat, i.e., boosting. There are several novel ARVs that are less widely used or are still in clinical trials, such as attachment inhibitors, maturation inhibitors, and capsid inhibitors. ART is usually used in combination. Typical combinations include two NRTIs as a backbone, along with one NNRTI, integrase inhibitor or boosted protease inhibitor as a base. Currently, the first line of combined ART, abbreviated as CART, consists of a single pill, taken once daily to be started as soon as an HIV+ diagnosis is established. Pre-exposure prophylaxis, abbreviated as PrEP, is recommended for HIV-negative people with a substantial risk of getting an HIV infection and who do not always use condoms, e.g., individuals who engage in chemsex, by getting a daily or intermittent dose of ARVs according to medical recommendation. In addition, post-exposure prophylaxis, abbreviated as PEP, is possible within 48 to 72 hours after exposure to HIV in order to prevent infection, e.g., unsafe sex, needle stick accident. PEP includes counseling and administration of a 28-day course of ARVs. Pharmacists play an important role in helping patients initiate treatment and prevent early discontinuation. Treatment of chronic hepatitis C is a fast-evolving field with rapidly changing recommendations. Current treatment guidelines recommend directly acting antivirals once daily. There are 4 classes of directly acting antivirals that directly target HCV non-structural (NS) proteins essential to viral replication through different mechanisms: nucleoside and nucleotide NS5B polymerase inhibitors, NS3/4A protease inhibitors, PIs, NS5A inhibitors and non-nucleoside NS5B polymerase inhibitors, e.g., Cymprevir, Paritaprevir, Daclatavir, Ledipasvir, Ombetasvir, Sofosbuvir, and Dasabuvir. Treatment with DAAs can cure most patients within 12 weeks and a maximum of 24 weeks. However, the cost of directly acting antivirals remains very high in many countries. There remains a limited role for older regimens with pegylated interferon and ribavirin in certain cases. Despite the strong recommendation for treatment of nearly all HCV-infected patients, Pre-treatment assessment of a patient's understanding of treatment goals and provision of education about adherence and follow-up are extremely important, in addition to the essential viral genotype evaluation. A well-established therapeutic relationship between clinicians and patients remains crucial for optimal outcomes with direct-acting antiviral therapies. Additionally, in certain settings there remain factors that impact access to medications and the ability to deliver them to patients. In these settings, clinicians may still need to decide which patient should be treated first. The descriptions of unique populations discussed in these guidelines may help physicians make more informed treatment decisions for these groups. Several treatment guidelines can be accessed online for more guidance on HIV or Hepatitis C treatment, such as European Treatment Guidelines, recommendations of the International Antiviral Society USA Panel on Antiretroviral Treatment of HIV-positive adults, and the Swiss Association for the Study of the Liver, SASL, Expert Opinion Statement on the Treatment of Chronic Hepatitis C. Next we will discuss drug-related problems. Drug-related problems such as side effects, drug-drug interactions and poor adherence can be problematic, especially in CAR T that is a lifelong treatment. Novel ARVs may have fewer side effects than older generations. Table 33.1 summarizes side effects by antiretroviral class for the most widely used treatment classes. There are also some adverse effects related to drug-food interactions and drug-drug interactions between two or more ARVs and also between ARVs and co-treatments. For example, as PIs are metabolized by cytochrome, abbreviated as CY, P450, hence their concomitant use with other drugs that are metabolized by CYP450 can result in significant drug-drug interactions with prescribed, OTC and herbal treatments, e.g., simvastatin, midazolam, ethanyl-lestradiol, ergot derivates, St. John's wort. Boosters such as low-dose ritonavir or corbc-stat are potent inhibitors of CYP450. Anti-acid drugs modify the bioavailability of several ARVs. The University of Liverpool websites are a significant resource for pharmacists to check for drug-drug interaction in HIV therapy. On contrary to former interferon and ribavirin-based treatments, directly acting antivirals are well tolerated and easier to take. E.g., some directly acting antivirals are available as one pill a day. Main side effects are nausea, diarrhea, headache, and fatigue. Other side effects such as rash, photosensitivity, pruritus, e.g., Sympravir, or cardiovascular, e.g., sofosbuvir, are more drug-specific. Some directly acting antivirals such as dasibuvir and elbasvir, grazoprevir are substrates of CYP450 and other directly acting antivirals are moderate inhibitors of CYP450 such as asunaprevir. Therefore they have a direct drug-drug interaction with ARVs and other CYP450 inhibitors or inducers. An interactions checker is available on the Liverpool's University website. HCV-infected patients with liver cirrhosis may have an impaired 450 cypriot pounds function that puts them at a higher risk of drug-drug interactions and drug toxicity. Adherence to medication is an important aspect, especially in the treatment of viral infections. See also Chapter 5. Non-adherence to ART is associated with virologic failure, development of drug-resistant viral mutations and a higher risk of mortality. Hence better understanding of what factors predict poor adherence is needed. The scientific literature is inconclusive about different social and demographic factors such as ethnicity, education level, income level, housing situation or gender as predictors of non-adherence. Even though individual studies in specific populations may find a link between particular factors and non-adherence, meta-analyses lack consistent findings. In the context of HIV infection, alcohol use, depression, anxiety, and cognitive disorders are associated with a greater risk of non-adherence in several studies, and lower adherence was observed among adolescents infected with HIV. As HIV is still highly stigmatized among different communities in different parts of the world, patients may be more liable to develop anxiety or psychological disorders, which put them at a risk of non-adherence. As directly acting antivirals are relatively newer drugs, wide-scale studies measuring adherence to directly acting antivirals are not yet published. However, existing evidence from the US shows high adherence over 12 weeks of directly acting antiviral intake. Adherence to directly acting antiviral therapy is easier than with older interferon-based regimens due to markedly decreased toxicity, easier dosing schedule, shorter course of treatment, and providers' adherence reinforcement due to the costs of directly acting antiviral. Pause the video and carefully scrutinize Table 33.1 summarizing antiretroviral treatment classes and severe side effects. Next we will look at treatment goals. For HIV patients, the ultimate treatment goal is a durable viral suppression, below 50 copies per milliliter HIV RNA viral load, and a normal CD4 lymphocyte count, above 400 cells per millimeter cubed. For hepatitis C patients, the treatment goal is to achieve a sustained virologic response, abbreviated as SVR, defined as undetectable HCV RNA for 24 weeks following completion of therapy. There is evidence that sustained virologic response can reverse the early effects of fibrosis and prevent the progression into hepatocellular carcinoma. We will now discuss self-management. Self-management involves several concepts such as patient education, integrated person-centered care, and behavioral change. Patients can learn to self-manage their treatment using several tools such as electronic pillboxes, phone applications, apps, or alarm reminders about medication intake timing and pillbox organizers that were shown to decrease unintentional non-adherence. Technology-based tools include telephone support, including SMS, and web-based interventions, including the aforementioned apps. Such tools have the potential to keep the patient in close contact with the provider and help the provider address regularly both patient intentional and unintentional non-adherent behaviors and adjust the treatment to patient's needs. Therefore, patients should be encouraged to share their electronic or digital data with healthcare providers, including pharmacists. Regarding self-management of side effects, several methods can be of help to patients. In case of mild depression, insomnia, or anxiety, regular exercise and relaxation exercises can help alleviate symptoms. For gastric discomfort, addressing patients' needs in terms of best food medicines combinations, timing of medicine intake, and eating habits provide relief for many patients. For dry skin, using moisturizing creams that are available over the counter can be of help. Finally, in case of dry mouth, drinking plenty of water and brushing teeth regularly is suggested. In case of more severe side effects, alternative regimens might be the best solution, which have to be discussed with the prescriber. And now we will look at pharmaceutical care in HIV and hepatitis C virus. Let's begin with existing evidence. Several studies in HIV provide evidence on the positive impact of pharmacists on the clinical outcomes expressed by higher rates of viral suppression and greater increases in CD4 cell count, reduced pill burden and dosing frequency, and higher adherence of HIV patients. A study that compared two treating arms for 1571 HIV-positive individuals initiating their antiretroviral therapy, one including a pharmacist and the other not, showed that patients exposed to a pharmacist were more likely to achieve viral suppression than those who did not. Another study showed that pharmacist-led interventions, such as adherence counseling and regimen adjustment, were associated with better treatment outcomes such as sustained undetectable viral load. A pharmacist-led behavioral intervention among non-adherent HIV-positive individuals also demonstrated increased retention to pharmacy refill and clinic appointments, fewer hospitalizations, and decreased number of opportunistic infections. For hepatitis C infections, clinical pharmacists play an important role in checking for hepatitis A and B virus immunizations for those infected with hepatitis C virus, managing drug-drug interactions, and inpatient counseling, education, and adherence monitoring. An interprofessional intervention including pharmacists showed comparable clinical outcomes of sustained SVR among the community-based intervention participants to those who participated in clinical trials. The addition of pharmacists to a team of hepatologists and nurses resulted in an increase in medication adherence and SVR rates in hepatitis C virus patients. Finally, including pharmacists with experience in hepatitis C virus in care provision, demonstrated better hepatitis C virus viral load monitoring and appropriate management of directly acting antiviral-related side effects. We will now discuss the approach to care or interventions. According to many pharmaceutical care guidelines, the pharmacist's role in caring for patients with HIV, AIDS and/or hepatitis C virus infection is part of the Medication Therapy Management Services, MTMs, which include the following. 1. Patient counseling and education about the disease, either directly or through referring patients to specialist centers or trusted information sources such as books, leaflets or online websites. See also Chapter 4. 2. Checking patient readiness before treatment initiation, especially because, since recently, CART is started just after diagnosis. 3. Reinforcing medication adherence on the long term, and 4. Monitoring response to therapy, managing adverse effects, and drug-drug interactions. In this chapter, we will focus on the role of the pharmacist in adherence-enhancing interventions. Based on the dimensions of adherence defined by the WHO, described in Chapter 5, the barriers and facilitators to adherence and consequently the levels of an adherence-enhancing intervention can be grouped into three main factors or levels. 1. Cognitive and psychosocial factors. 2. Environmental and organizational factors, and 3. Treatment-related factors. Even though the role of pharmacists in the treatment of HIV and hepatitis C virus patients is well documented in the literature, the impact of their role in evidence-based intervention studies that include adherence data and have a large sample size is not well described. However, there are few examples that we can share in this chapter. Pharmacists should ensure continuous access to ARVs whenever it is in their capacity to avoid any treatment discontinuation and a risk of viral rebound. For example, by maintaining contact with the treating physicians to guarantee a continuous access to ARV by renewing prescriptions as timely as possible. Further, due to the success of ART, the HIV population is aging and is at risk of developing comorbidities. That necessitates that the pharmacist should reinforce medication adherence of all prescribed treatments from various prescribers while minimizing the pill burden and side effects. They should also invite their patients to inform them if they collect different treatments from different pharmacies or online to advise them on possible drug-drug interactions. This may be of special importance as some patients may obtain their HIV treatments from pharmacies that differ from the pharmacies where they obtain their other co-treatments to maintain their confidentiality. In some settings, pharmacists can play a role in HIV testing and counseling high-risk groups, e.g., when providing the morning after PEP pill. Drug holidays can be detrimental in HIV and hepatitis C virus. Hence, it is the role of the pharmacist to advise patients on how to make up for missed doses. For example, the time span during which a missed dose can be taken, to take the next dose at the scheduled time and not to take multiple doses at once to compensate for their missed doses. HIV-related stigma has been known as a barrier to access to treatment, care, and prevention. Pharmacists along with other healthcare providers can also play an important role in reducing HIV-related stigma. This can be done through providing a welcoming environment for HIV-positive individuals who come to their working places within the healthcare system, e.g., pharmacies or hospitals. At the community pharmacy of the Department of Ambulatory Care and Community Medicine, University of Lausanne, Switzerland, in collaboration with the Infectious Diseases Service of the University Hospital, a medication adherence program has been implemented. Motivational interviewing is combined to longitudinal medication adherence monitoring via electronic monitors, MEMSTM, ARDEX MWV, Sion, Switzerland, and pill count. Electronic adherence data are shown to the patient as feedback and a report is sent to the physician and nurse after each interview to ensure continuity in care. HIV-positive patients who participated in this intervention were shown to have an increased retention in care versus patients who did not. A cohort study in Canada compared patients' adherence when cared for in a tertiary AIDS care hospital outpatient pharmacy, where pharmacists provided medication counseling, individualized regimens, and adverse effect monitoring, with those cared for in family physicians' offices. Results show higher adherence rates, that is greater than 90%, among those who had contact with pharmacists, that is 70% of patients who had contact versus 55% of patients who did not have contact with pharmacists. In a liver unit in Spain, a multidisciplinary support program, abbreviated as MSP, among 447 HCV patients, showed that adherence and SVR rates were higher among participating patients versus control group, that is 94.6 and 77.1%, respectively, for multidisciplinary support program versus 78.9 and 61.9% for controls. Next we will discuss biomarkers. Important biomarkers in HIV infection are plasma HIV RNA levels, which can be determined through using polymerase chain reaction (PCR) assay with a lower detection level of either 50 copies per milliliter or in new generation equipment 20 copies per milliliter. HIV RNA levels can be dichotomized into detectable or not, based on the lower detection level of the PCR assay. CD4 lymphocyte count is the second important biomarker and can be measured using standard flow cytometry. A normal range for CD4 cells is about 500 to 1200 cells mm³. In chronic HCV infection, liver-related biomarkers have been developed to predict liver fibrosis or cirrhosis and hepatocellular carcinoma. These include HCV genotype, serum HCV-RNA load, stage of fibrosis, and child Pew score, total bilirubin, albumin, INR, ascites, and encephalopathy. Next we will progress to outcomes that matter. Outcomes that have to be addressed in HIV and hepatitis C can be classified according to the economic, clinical, and humanistic outcomes, abbreviated as ECHOS, model of pharmaceutical care services. In HIV, pharmacists can have direct influence on direct clinical outcomes, namely viral load and CD4 count. Indeed, their role is crucial in supporting, enhancing adherence to ARVs and co-treatments, by reducing pill burden and frequency of dosing, increasing retention in care, reducing incidence of opportunistic infections and reducing ARV-related toxicity. Non-adherence to antiretrovirals can lead to unwanted outcomes such as viral resistance that is difficult to treat and costly to the healthcare system. In addition, the cost of treating HIV-related opportunistic infections can be burdensome to the healthcare system as well. Evidence shows that patients with sustained undetectable HIV-RNA viral load and higher CD4 cell counts, fewer HIV symptoms, lower pill burden, and higher adherence have improved survival rates, higher health-related quality of life, abbreviated as HRQOL, and can attend to daily living tasks. Therefore, increasing the higher health-related quality of life of PLW-HIV has become an important treatment goal. Higher health-related quality of life can be enhanced through several physical, psychological, and social determinants of health. Pharmacists can play an important role in health promotion, patient therapeutic education, and psychosocial counseling. Pharmacists should encourage practical and emotional support whenever possible from significant others of patients to facilitate long-term medication adherence. They can decrease the stigma surrounding HIV patients through their professional, empathic, and supportive attitude. They should also support pregnant HIV-positive women on CAR-T adherence to avoid vertical transmission to their newborns. Patients with hepatitis C virus are known to have reduced work productivity and higher health-related quality of life, high rates of all-cause hospitalizations and mortality, which represent an economic burden to the patients and the healthcare system. Successful treatment should reduce liver-related morbidity and mortality, hospitalization rates, and reduced risk of developing hepatocellular carcinoma. Further, as hepatitis C is curable for the first time with the introduction of directly acting antivirals that are very costly, it is the role of the pharmacists to ensure access to treatments for eligible patients, reinforce patients' strict persistence and adherence to treatment, help patients manage their side effects if any, and check the presence of drug-drug interactions. And now we will discuss documenting care provided. Appropriate documentation of activities of pharmaceutical care is important for efficient communication among healthcare provider regarding the patients and to collect evidence on the role of the pharmacist in the care continuum. See also Chapter 8. Documentation can be in patient records or medical charts, or in individual pharmacy records. The records can be in digital form or paper-based and can also be part of a standalone computer database or, whenever possible, part of an integrated electronic health records database. Next we will consider a case scenario. In this case scenario, we will work on enhancing adherence by identifying the barriers and facilitators to adherence within the three main levels as described earlier. This approach is applied in a pharmacist-led interdisciplinary adherence-enhancing intervention in Switzerland, and can be adapted elsewhere in the world. The three levels are: 1. Cognitive and psychosocial factors. 2. Environmental and organizational factors. And 3. Treatment-related factors. Female patient in her 40s, originally from West Sub-Saharan Africa, has 4 children and is single. She was diagnosed with HIV 4 years ago following sexual assault. She was prescribed efavirenz, emtricitabine, tenofovir disoproxil fumarate once daily. The viral load when starting treatment was 39,000 copies per milliliter. The viral load 1 month later was undetectable with CD4 count 550 cell per milliliter cube. Her taking adherence as measured by electronic monitoring is around 95%, with regular medication intake until 1 year later after starting treatment. Starting the following year, she stopped going to her pharmacy and medical visits, her adherence level dropped, and viral load was detectable again. 1. We now look at cognitive and psychosocial factors. Barriers. She is single, as she believes that it is impossible to find a partner who would accept her HIV diagnosis, and she does not want to grow old alone. She does not share with her relatives that she is HIV positive, feels socially isolated, and sometimes she cries herself to sleep. Facilitators. She accepts her treatment and she can see the effect of treatment on her health. She has a strong will to live to look after her 4 children. She knows how to regularly discipline her medication intake around the same time every night, before she goes to sleep. 2. Next we will discuss environmental and organizational factors. Barriers. Sometimes she works in the night, so the medication intake hours are affected as they are different to her usual habits, taking them before going to bed. And now we will look at facilitators. She knows how to associate medication intake timing with a daily behavior, which is going to bed, which makes it hard to forget. She also keeps her medicine in a drawer next to her bed, so it helps her remember. 3. Finally, we will look at treatment-related factors. Regarding barriers, she complains from nausea, especially if she takes her medication on an empty stomach. She also suffers from fatigue and headaches. Regarding facilitators, she says that her side effects are less frequent over time, compared to daily symptoms in the beginning of the treatment initiation. The main difficulties with this patient are that she has a difficult social status, being a single mother to 4 children without a fixed employment. She also feels stigmatized by her HIV status. Pharmaceutical care support should combine best pharmacological knowledge with advanced communication competences, e.g., motivational interviewing. For example, to empower her by evoking her ARV success in the past, and what this means for her today in terms of eventually resuming her treatment intake. The pharmacist should monitor the evolution of fatigue from one visit to the next one. In case the fatigue is persistent, it might be a side effect of efavirenz, and the pharmacist should evaluate the possibilities to switch to a non-efavirenz containing ARV regimen with the prescriber. If the patient has difficulties adhering to an evening dose due to working night shifts, the pharmacist can recommend alternative ARVs that can be taken in the morning. As physicians are attentive to side effects that impair clinical functionalities, e.g., liver, kidney, heart, it is the role of the pharmacists to pay attention to the patient's HRQOL by monitoring milder side effects such as nausea or fatigue in this case study. If psychosocial aid is possible, the pharmacist can recommend a psychologist or psychosocial nurse that can work with the patient to help her overcome her distress about her HIV status, and work with her in view of the decreased risk of HIV transmission among serodiscordant couples. One partner is HIV negative and the other is HIV positive. when specific clinical conditions are met and discussed with the infectious disease physician. Lastly, the pharmacist should establish with the patient the potential use of refill reminders to keep her in care. Thank you.